Glioblastoma is the most common, but also the most malignant brain tumour that you can get. And unfortunately, the treatment options for glioblastoma are very limited. So the standard of care hasn't changed in about 20 years. So we're still restricted to radiotherapy, chemotherapy, but surgical resection. So without treatment, patient survival is limited to 3 months, which exemplifies how aggressive this disease is. But even with the standard of care that we can offer at the minute, so with chemoradiotherapy and surgery, that is only extended to about 14 months. So it's still one of the most rapidly growing and fatal tumours.
So we're getting clinical samples from Salford Royal from patients who've suffered from glioblastoma and then consented to have their tissue used in research. And then what we're doing is we're applying some really cutting edge technologies to deconstruct the cells that are in those samples. So we're hoping that our research will give us a complete new understanding into how cells within the glioblastoma are spatially organised, which will give us insights into the disease mechanisms that we can then target therapeutically.
So within glioblastoma, the tumour microenvironment is very heterogeneous and very complex. So you have different tumour subclones that respond differently to treatments and have different progression rates, but you also have the surrounding microenvironment, which in GBM's case represents a lot of macrophages.
So whereas previous technologies really were limited in their ability to look at the spatial location of all the cells in the tumour, we now have technologies available which allow us to know exactly whereabouts the cells are in a tumour, such as Hyperion imaging mass cytometry and spatial transcriptomics. And we want to combine all these different modalities to really be able to spatially map all the cells in the tumour, which we've never been able to do before. So previously we've been limited to taking the cells out and looking at them individually. But now we can sort of put the jigsaw of where those cells are back together and look at the entire picture of how the cells are organised in the tumour microenvironment, which is completely new.
It will mean that, for one, we'll be able to identify whether there are certain trends within the patient itself. So the tumour is so heterogeneous that we need to understand whether the certain clones preferentially locate certain regions so that we can identify treatments that will either counter the interactions that, say, occur between the macrophages and the neoplastic cells in a certain zone, which means that we can get rid of that immunosuppressive environment and target that. But it will also mean that if we look across patients at how this heterogeneity occurs, that we can investigate whether certain clusters of tumour cells in certain locations correlates with survival or good responses or poor responses to treatments. So we work together very closely with the neurosurgeons, who are the ones that not only deal with this disease on a day-to-day basis in a patient-facing role and having to do the surgeries, but they understand this from a clinical viewpoint, whereas we come at it with a biological one. So they're making sure that the biological questions that we're asking in order to try and understand how GBM works and why it's such a deadly disease, the answers that we get are also relevant to them so that they can modify or hopefully influence therapeutic options and improve them in the future.